Dr. Jaishil and dear friends, the role of dual shampoo based imaging system, that's Galili. There is no financial interest. Now, what do you see in a normal camera? You see like this, so you don't get this picture very clear. While in shampoo image, you get a 3D picture so that you get a true elevation, and once you have a true elevation, you can derive any maps from that numerically. Now, what is the issue basically? In topography or charactermetry, what is happening that the central data you never get because the fixation of the machine is right bang into the center. So you never get these readings very clearly. While in shampoo image, it takes a slice 180 degree across the cornea. So you get maximum readings bang into the center. That's what we want in a refractive surgery and IR power calculation. And basically you get a nasal shadows in topography because of a slice of the cornea. In shampoo image, you get limbus to limbus clear readings all throughout. Now if you see that this is what we are talking about, this is how a normal cornea will look, but if you see the posterior surface, that's where the keratoconus starts. You will start getting signs here, which you would not get with any anterior topographer. You need to have a shampoo image. Now, what should be the strategy for a shampoo image? First, always look at the anterior elevation, then the posterior elevation, tachymetry and its distribution, and then you see the curvature map. This should be last, which is first and most important in anterior other topographers. If there is asymmetry, that means something is wrong somewhere. Now, as far as the Galili is concerned, it is taking yellow as a borderline, that is 47 diopters, 500 micron thickness, and 10 to 15 micron of elevation, or you can say ectasia. And all other colors show that below average and as a green normal, and you can say red and orange is to be having ectasia. Now, this is very important slide where it shows that how the elevation is compared. It is compared to the sea level. Now, if you see, this is what I was trying to show you, sir. Now, this is the best fit sphere, you can say, and to which the cornea is compared. Now, normal cornea is basically aspheric, that is prolate, that is steep in the center and flat at the periphery, to which all the corneas are basically compared. Now, if you see the curvature maps and elevation maps, the color coding is exactly opposite. And this is very important to understand. Why is that? Because it is basically comparing it to the sea level. So you'll always see that the colors are getting exchanged in elevation map and the curvature map. And once you understand this slide, then everything becomes very easy. The indices which are used is keratoconus predictive index, KPI in Galili, and in Pentacam it's called as a BAD or a Belen display, which has already been told. Now, KPI basically up to 10% you can say normal, 10 to 20% is suspicious or borderline, and about 20 to say 25% we don't do any case, but we know that definitely there has to be something wrong. About 30% is definite keratoconus or pellucid marginal degeneration. Any elevation which is more than say 8 to 10 micron above the normal, depending upon the zone which you are considering, is suspicious. So it will depend upon where it is starting and whether it is on the anterior surface or the posterior surface. But you can say anything we can say about 8 micron, you should be suspicious about. These are all obvious cases where you get an elevation more than 20 micron. Colors are itself will be more diagnostic. Now, there are many indices which is here. One is keratoconus predictive index, you can say, and keratoconus probability index, cone location and magnitude index, and percentage probability keratoconus. And you will have a multiple data which will eventually lead to give you something like this and this one. Always have a one step, you can say one diopter step, so it will be easy to detect, because if you go on a lower one, it will increase the noise. If you increase it, the asymmetry will be too much, and you may start suspecting normal as abnormal. Now, what is different in double shampoo or you can say Galili? It's a double shampoo so that when the two slices are moving each other, basically motion compensation, like when patient is blinking or the tape film is getting disturbed, at that time these two will average and give you more and more you can say accurate reading than a single camera. Like single camera is moving, and if you are blinking, eye is moving, you may have some reading you can say which are not accurate. That's the most important part about the double shampoo camera. You will get a curvature topography, that is anterior curvature and posterior curvature. You will get a best fit sphere elevation topography, anterior and posterior surface, which will start indicating what is going wrong somewhere. So this is basically anterior topography, and this is the posterior topography. Why are we using instantaneous? To magnify the defect. So, but don't primarily see instantaneous. You can see axial, that will give you overview, and this will magnify, you can say, any changes which are there, so that you can start suspecting that something is going wrong somewhere. Now best fit sphere is not the only way to study the posterior surface. You should have what is called as the best fit toric sphere, or BFTA, which will give you a diagnosis for the cornea and for the premium IOLs. Let's see how. Now if you see that maps, BFF will give the toricity and bulging, while BFTA, that is best fit toric sphere, will give you asymmetry and the smoothness in the cornea. Now if you see that both surfaces, that you can say anterior BSF and posterior one, asymmetric, this is a normal patient. Again here anterior asymmetric is and posterior asymmetry is there. You know, something is going wrong somewhere here. Symmetry in the flatter axis, asymmetry in the flatter axis will be shown here, and asymmetry in the steeper axis will be shown here. So, you know, once you have both BFS and BFTA, the diagnosis becomes more easier. A smaller defect can be detected earlier, both for the cornea and for the, you can say, cataract surgery. Now, this is a Ka index or a Kahneman arc index, which shows that what is the best fit toric sphere deviating from the normal. Now, that's where, you know, most of your patients of cataract will also fall, and a cone which is available in, you can say, keratoconus patients will be detected. This is how it is shown that, you know, how it will, toric surface it changes, what it is going to give you. Sorry. Now, this is very important, the pachymetry in each one. Like if you see a Barian embryology display or a pentacam, it is going to take average from center to periphery, divide into multiple indexes and give you the pachymetric distribution. In other things, it is going to see that at what level you are going to measure the pachymetry. Are you going to take it as a 4 to 7 steps? Are you going to take 10 to 15 steps? This is going to magnify the defect. So always use it. Once you have some suspicion, then you can go here and magnify. Otherwise, normally if you try and do, even the artifact may appear as an abnormality, or you can say ectasia. Now, signs of, you know, once you start having something as a bulging or a keratoconus, then the, you know, that is quite more obvious. This is a baby bow tie. You can see a crab-like, you can bulging, you know, which is quite obvious here. Now this is what it is called as, you know, you can say peninsula, or you can say the early sign, baby bow tie. You know, we can have a crab-like, you can say, picture with a lot of raids showing obvious bulging. And you can have a CLMI again here, which shows that, you know, there is a bulging which is starting into the center. Is a crab-like picture again, and it will also give a wavefront data also. Where you are going to have, you can say, different signs of coma, trefoil and spherical abrasions, which is again more important for the IL power calculation. This is what it shows, these patients. Venetian glass signs is basically, whenever you start getting the keratoconus, it is inferiorly and inferior temporally. That's where, you know, it will start, and so you start getting bulging like this. Cone location magnetic index, that is CLMI, and KPI, that is keratoconus period index, both are more or less same. They will give you more or less same, you can say, picture, and both can be comparable and will give you more or less same, you can say, data. Now, there are 56 Galilei parameters which are used, that is curvature parameters, elevation parameters and pachymetric parameters, to come to a conclusion to give you indice. We can say that is KPI, K probability, or you can say cone location magnetic index, or, you know, so basically it's not a single parameter which has been used. The software uses multiple parameters to come to a conclusion, and that's how it is going to look. So in summary, if you see that posterior float BSF is not the only way to study the posterior surface. Maximum posterior BSF is good indicator of bulging. Ka index is basically a best fit toric sphere maps is good indicator of asymmetry and surface changes. CLMI is a good indicator of asymmetry of the surface. K max is again a good index of the stiffening. And E2 is basically the square eccentricity is a good indicator for multifocality of the cornea. Now this is very important for the IL selection, especially in multifocal ILs or toric multifocal ILs. KPI, K-probe, IS, that is inferior and superior, you can say Rabinowitz index, are basically derived from the anterior curvature and should be used quite cautiously, especially when the artifacts are there. Traditionally, quad map is not the only thing. You should have a BFTA also, that is toric sphere, which will consider that this patient is going into keratoconus or not. Thanks a lot. Thank you.